other risk factors are diabetes mellitus, microalbuminuria, or GFR less than 60, age older than 55 years old for men and older than 65 for women, family history of premature cardiovascular disorders. Premature cardiovascular disorder is less than 55 for men and less than 65 for women. Men under age 55 or women under age 65. So another risk factors for hypertension, they are called secondary risk factors, inadjustable risk factors, or identifiable risk factors, like renal diseases, chronic kidney diseases, glomerular diseases, vascular disorders, oral contraceptive pills can also cause overt hypertension. Drug-induced, like non-steroidal anti-inflammatory medications, antidepressant also can induce hypertension. Chronic alcohol intake and alcohol abuse can raise blood pressure. Pheochromocytoma, it's a tumor in the adrenal medulla that release norepinephrine and epinephrine, follows the rule of 10. 10% of the tumor are malignant, 10% are above the age of 60, 10% are extra adrenal, and 10% are pure norepinephrine release tumor. So another factor that is primary aldosteronism, the presence of primary mineralocorticoid excesses, which should be suspected in patients with hypertension, hypokalemia, and metabolic alkalosis. However, some patients may have normal plasma potassium concentration, and the prevalence of this disorder should also be considered in patients with resistant hypertension who are not responding to the medication. So I will tell you what is primary mineralocorticoid excesses. Actually, mineralocorticoids are steroids released from the adrenal cortex, and mainly they are composed of aldosterone, and aldosterone work in aldosterone receptors to reabsorb water and sodium from the kidneys and from the GIT and from the salivary gland. So the aldosterone is stimulated via hypokalemia or hyperkalemia, guys.
معلش ممكن تعيد السؤال تاني؟
What stimulates aldosterone release? Hypokalemia or hyperkalemia?
I'm not sure.
It causes hypokalemia. It causes sodium and water retention and excretion of potassium. So it causes hypokalemia. So it is stimulated by hyperkalemia, okay, and it's stimulated by low blood pressure and angiotensin. So angiotensin and hyperkalemia and potassium stimulate aldosterone release, and the aldosterone causes sodium and water retention. The primary excess of aldosterone, the primary mineralocorticoid excess, is a disorder associated with something called beta hydrogenase 17 hydroxy, beta dehydrogenase deficiency, or leucorin poisoning.
شنو poisoning؟
Leucorin poisoning. Leucorin is a substance that used in synthesis of food, sometimes synthesis of hair products, skin products. It's a substance that inhibits this enzyme, inhibits 17 hydroxy beta dehydrogenase. 17 beta hydroxy dehydrogenase. Which enzyme is this? You have to know that there is a 70% to 75% homology between the receptors of the mineralocorticoids and the corticosteroids. Okay, so in the renal system, the renal tubules, beside the steroid receptors and the mineralocorticoid receptors, i.e., aldosterone receptors, there is this enzyme 17 beta hydroxy dehydrogenase enzyme. This enzyme in the cell is found close to the receptors, aldosterone receptors. Do you know why? Because if the receptor is left without this enzyme, any increase in the level of steroids will activate these receptors because of the homology between the aldosterone receptor and the corticosteroid receptor. So if there is a very high level of corticosteroids, it will bind to the aldosterone receptor and activate it. The presence of this enzyme converts the corticosteroids to weak steroids that do not work in this receptor. Okay, so any deficiency of this enzyme will lead to abnormal activation of aldosterone receptor, and this is called mineralocorticoid excesses. Primary, if it's primary, this means there is a deficiency of this enzyme. If it's secondary, it's leukorrhea poisoning. Okay. So renovascular diseases like renal artery stenosis due to muscular hypertrophy or localized atherosclerosis can cause secondary hypertension, which is resistant to medications, and also Cushing syndrome can cause hypertension. Also, uh, high excessive growth hormone causes acromegaly. Acromegaly can cause hypertension also. Hypothyroidism, hyperthyroidism, hyperparathyroidism may also induce hypertension. Obstructive sleep apnea causes hypertension. Coarctation of the aorta also causes hypertension. All these are causes of secondary hypertension. So why do you think hyperthyroidism causes high blood pressure? So coarctation of the aorta is another cause of secondary hypertension. And now we finished the risk factors and the classification of hypertension according to the GNC or GNR 8, and we finished the general principle. We will go for the complications and investigations and management of patient with hypertension. So the complications of high blood pressure includes renal diseases and cardiovascular risk factors increase the risk for complications from high blood pressure. Patient can develop congestive heart failure and left ventricular hypertrophy, coronary artery diseases, increase mortality and morbidity overall, and peripheral vascular disease can occur in patients with hypertension. Renal diseases can occur, and stroke can occur. Do you know why the patient who is having hypertension may have peripheral vascular diseases and coronary artery diseases and stroke?
معلش
Do
شنو؟
you know the pathophysiology of coronary artery disease, peripheral vascular diseases, and stroke in patients with hypertension?
ما مش it has to do with في peripheral vascular disease إنه the high flow damages the بيعمل a higher shear stress on the blood vessels.
Yes,
الحالة
بيعمل
دي
شيء ستريس للفيزلز.
فالحالة دي ممكن تزيد the risk of atherosclerosis أو damage عموما في ال blood vessel بجوا في ال endothelial lining.
اوكي يعني endothelial damage it may be one of the causes, but mainly the cause for these conditions is that when there is a hypertension, there is a decreased blood supply to the arteries themselves. Apart from the endothelial damage because of the shear stress, there is a decrease in the vasorum blood flow.
Okay.
Yeah, when there is a decrease in the vasorum blood flow, there is a weakening of the blood vessels. And when there is a weakening of the intima of the blood vessel, the intima of the blood vessel when weakened, and the pressure is high, the protein filtrate inside the walls of the vessel. And when the protein filtrate, it accumulate and it causes a bulging and narrow the vessel further and further and further. And sometimes aneurysm may occur.
Okay.
This is why these patients develop peripheral vascular diseases and atherosclerosis, renal vascular diseases, and CVA, because they may develop lacunar stroke.
Okay.
So target organ damage may affect the heart and cause left ventricular hypertrophy because of the increased afterload, and the increased afterload increases the pressure, and increasing the pressure increases the tension, and for us to reduce the tension we increase the radius. Angina or prior myocardial infarction, and this occur because of the left ventricular hypertrophy itself and because of the atherosclerosis in the coronary arteries. So coronary artery and myocardial infarction and angina can be related to the coronary artery diseases or non-coronary artery disease. If it's due to coronary artery disease, atherosclerosis. If it's not, this is left ventricular hypertrophy, increased demand. Prior coronary revascularization and heart failure may occur. In the brain, ischemic or transient ischemic stroke, hemorrhage may occur, especially in patients who is taken aspirin as primary prevention without blood pressure control, and hypertensive encephalopathy, which is characterized by clinical blindness, loss of consciousness, and edema in the occipital loop. Reversible posterior leukoencephalopathy, it's called. Chronic kidney diseases can occur also in patients with hypertension. Hypertensive nephrocalcinosis can occur, and renal peripheral artery diseases and retinopathy. Okay, so we finished the complications associated with hypertension.